So this is the responsive neurostimulator for epilepsy. Before you get into the operating room to place a RNS, you have to do some preoperative planning. You have to know what kind of electrodes you're going to use and where you're going to place them. And it's a little bit different than something like deep brain stimulation, where you're kind of going the same place every time, right frontal, left frontal, same kind of placement of the Burr hole. Might vary a little bit, centimeter or two, but overall it's the same. This is very different. You might be putting in occipital Burr holes in one case, or a frontal Burr hole in another, or a left occipital and a right frontal. Could be anywhere. So you really have to plan out beforehand what you're going to use and make sure that you're positioning your patient in a way that you're going to be able to achieve your goals. You can see they have a number of different electrodes that are available. There are the strips. All the strips are for contact, and there are different lengths of these strips. And then there are also depth electrodes, and there are two different length depth electrodes, the 44 centimeter, which is what this is, and a 30 centimeter, which is a bit shorter. And then there's also different distances for the contacts of the depth electrode as well. There's a 10 millimeter intercontact distance, and I think, 3.5 millimeter, I think, for this one here. And so if you're going after a little deep dysplasia or something, you might want to use this one with the 3.5 between each. Most of the time when we're stimulating the mesial temporal lobe, the hippocampus and amygdala, we use the 10 millimeter intercontact distance electrodes. And that's what we'll be showing today. As you can see, like all the other companies, they have a Burr hole cover here that we'll be incorporating into the surgery as well. And the type of electrodes you place might determine what you choose, not just for positioning, but the kind of delivery system you're going to use. So if you're placing two strips, you probably just need Brainlab or Stealth and be pointing to the area where you want to make a Burr hole and then slide in your strip into the appropriate place. Whereas if you're placing a depth, you're going to want to have a stereotactic device of some kind. And that might be a Lexel, CRW, could be a Vario guide, or it might be a robot. And so for this demonstration, I'm going to show the Vario guide, which is from Brainlab, alongside the Arrow, which is the intraoperative CT, also from Brainlab. For a bilateral occipital electrode placement for NeuroPace, I typically will use a Lexel frame because it is a little bit more accurate than the Vario guide. The Vario guide is very good for kind of getting anywhere in the head and being able to move quickly from one place to the other, and probably has about a 2 to 3 millimeter accuracy, but it's not quite as accurate as the Lexel frame. What does make it, I think, more accurate than some other frameless alternatives is that you can actually get a CT registration at the time once you're all positioned, and then that will register the patient to virtual space. And so the co-registration error, you don't have to do any surface registration, which can lead to inaccuracy. So again, I would normally use a Lexel frame for this, but I'm going to demonstrate with the Vario guide because we've been doing a lot of other frame-based stuff. I do tend to position patients with a Lexel base frame because it's a very good head holder and it kind of gets out of the way better than a typical Mayfield head holder. You do have to be careful, though, to position, particularly when you're doing a hippocampal depth electrode placement. You're always coming through the kind of parieto occipital region. You have to be careful to place your frame low enough that these screws are not going to be in the way of your Burr hole. So again, thinking about your pre-planning is important. And so we've already put the frame on. We've actually gotten a scan with the reference frame in place, and you can see that we've created a trajectory right here. This is a left hippocampal depth electrode, and Dr. Willey kind of went through the targeting for something like this. It's very similar. It's okay? The trajectory and placement for a depth electrode for hippocampal stimulation is fairly similar to the same trajectory you'd use for visual aids. You don't have quite the considerations of having to worry about, the spread of any energy, so you have a little more flexibility, but I like to try to organize it so that I will have one contact in the amygdala, another contact in the hippocampal head, the third contact in the hippocampal mid-body, and then another one in the tail. And so you can see here, I've also tried to avoid the ventricle just going up underneath. It's not, the concern about going through the ventricle is that you could have some CSF that would leak and make the brain deform a little bit. And then there's also a risk that you could bounce off of the hippocampus itself, particularly if it's shrunken and firm with hippocampal sclerosis. It can be pretty tough, and getting the cannula and the electrode through there could actually bounce off and go into the ventricle instead. So it is a little bit safer to, again, come up underneath the ventricle and enter the hippocampus from that location. So we have our trajectory in place, and now we're going to align our arm in line with the trajectory. I'm going to use a slotted cannula for this. If you're not using the Lexcel frame and a microdrive, then it's very difficult to hold the electrode still after it's placed while you're taking the cannula out. And so the 30 centimeter electrode actually isn't long enough to be used with a microdrive and a Lexcel frame. You really almost have to either use a robot or the VarioGuide arm if you're going to be using a 30 centimeter electrode. You do want to think about the length of your electrode that you choose, not just incorporates the distance to target from the skull, but also the distance that you're going to be tunneling the electrodes to the actual NeuroPace device. And in terms of positioning of the stimulator itself, I tend to use the parietal area. Try to go right parietal in general. The curvature of the device was actually designed for the parietal curvature of the skull, but there's no necessity to do that. You can put it anywhere you want in the head. You should think about successive battery changes, though. If you put it underneath the temporalis muscle, then you're going to have to take that temporalis down every time you want to do a battery change. And so we tend to try to base it up here, but if somebody's had previous craniotomy for epilepsy surgery before, that may change kind of your ideal location for the pulse generator itself. So you can see here I've placed it up here. What I tend to do is, before we do anything surgically, I'll place this template over the scalp and then mark out where I'm going to make my incision, and then usually make it a U-shaped incision. And when we do replacements for the battery, we usually try to make it so we only have to open up half of the incision to get the old stimulator out and put a new one in. So first we'll focus on the depth electrode, though. And so I'm going to be placing the slotted cannula in the holder. And actually, I'm going to move this up for placement. And I don't know, Katie, do you mind driving the... We'll have to go back to the cranial navigation. You got it? Great. Thanks. So we'll first do a rough alignment. And so here we are, the manual robot. And you just have to get it close enough to where it will say lock joint. And then we have to change each of the degrees of freedom. And you can see here the VarioGuide is not quite as rigid as a robot arm, but it still is quite solid. So I'm going to open up 1 degree of freedom to get that. It has to be able to see the eyes. Can you maybe move to the side? Yeah, that would be great. Well, nope. You know, try again. Nope. I think we may have to move the eye. You might have to bring it down, actually. Okay, there. Nope. If we can bring it down so it can see, this is, anybody uses stealth or brain lab a lot knows the pain of making sure it's always visible. Nope. Oh, we just had it. Hold on, I'm gonna reset these. Let's line that up again. All right. What's that? Yeah. There we go. So first we lock one joint. Okay. And then move to the next joint up. And this can be a bit tedious. All right. And then the last. Okay. And so then we'll place that down, and I mark on the skull where we're going to then make the burr hole. And then we'll have to take that out, take it away, and then we can make our burr hole. I might get, hold on, I'm going to get some gloves. Do we have any irrigation? All right. I don't think we've gotten all the way through. Let me see this. I think we don't have any patties, do we? Do you mind switching out to the other bit? So it hasn't gone all the way through the skull. What's that?
I'm just talking to
Oh.
my
Got the acorn, great. So we'll just widen out the burr hole here. Okay. Thank you. And do we have any suction as well?
no, not really.
No?
Get it to you.
All right. So we'll go ahead and put the burr hole cover on. And it's good to check the depth and make sure that you have enough clearance to be able to put the screws in. And there are 3 screws to place. The NeuroPace burr hole cover does not come with its own screws, so you'll have to use one from a tie mesh kit or something else. All right. Okay. So I won't put all 3 on just to save time. So then we'll have to come back in here, go back and realign again. So again, we're becoming the human robot. Okay. One joint. Oh. We can go to the next. All right. Okay. And last one. All right. Looks like our joint 2 is a little bit off. Huh. All right. So they should all be under 0.3 plus or minus. So now we have our trajectory aligned, and we can see that it's going to pass through the burr hole. So now we need to get our distance to target. So we measure our distance to target from the top of the vario guide, and that's 173 millimeters. So we will mark our slotted cannula to that same depth. 173. Do we have any tape? I guess we can probably just hold it here. Normally I would place some tape around here just so it won't go too deep, but we can actually hold it with the vario guide itself. And we'll go to the target depth. And it's important to know how long your cannula is. So the slotted cannula has a length of 20 centimeters. And so we will measure our electrode to be 20 centimeters as well. So the distance from here to target is now 20 centimeters. And so we'll place our depth electrode through the slotted cannula. And you have to be careful to keep it in the slot all the way down. And you'll know if you've gone into the ventricle as you're going through with the slotted cannula because you'll see CSF coming out. So now we know we're at target. The hardest part of this whole thing is then getting the electrode out from the slotted cannula. And basically, usually it's a two-person endeavor, and what you need is some bayonets, which we don't have. So usually if you get some suction, I put suction on the slotted cannula itself, and then that will pull the electrode out of the slot, and then you grab it with a pair of bayonets or something. I think for this, it's going to be, well, it popped out. So we'll do that, and then you can take off the Pac-Man and take out your slotted cannula. What I usually do too is to mark the electrode right at the surface of the brain so that you'll know if the electrode moves at all. And then we'll take out the slotted cannula. Thank you. And then we'll lay that over into one of the grooves and then pop in the plunger to lock it into place. Okay, so now we have our electrode in place. Typically for a bihippocampal patient, we'll do the same thing on the other side as well. And then we'll move on to the stimulator itself. So I usually try to undermine as well to allow some extra room for this wire to be looped. But we usually will just put that in here, put it underneath a nice antibiotic soaked gauze, and then move on to the stimulator. We've already done a craniectomy here. This always a full thickness craniectomy. First one that was ever put in, they tried to just make a trough in the skull, and it was not deep enough, and so immediately learned that we had to do a full thickness craniectomy every time. And the positioning of the craniectomy and the tray, also called the ferrule, is important because you want generally to not have the wires go across your incision line. Ideally, once you put this in, the wires are kind of out of the way and not at risk. As you can see, these electrode wires are a little bit flimsy and not well protected. And so generally, for this, I would want to come around here, and when we're designing where to place the ferrule, we made it such that the electrodes would come in underneath the skin where there's no incision line, okay? So we'll bring the, let's see, do we have a trocar? Do you know? You don't have a trocar, do you? We can try. Normally we have a tunneler that we can just bring it over from one to the other. Did you have a straw? Oh yeah, here we go. I don't know if we have anything quite long enough. Hold on, I'm gonna get this guy. So usually we use a short shunt tunneler to bring that over from one to the other. Let's see if I can get that. This might do it here. Let's see if I can get that to work. No. It's not wanting to go. Oh, there we go. All right, so we'll run the electrode through the straw. Typically use some suction to get that through. All right, so we'll pull that through. Again, we'll loop the wire around the outside, get rid of any extra, keep it out of the incision. We'll try to bring this wire underneath the skin to tunnel it out of the way. And then we want to bring it in so that it's going to come into the RNS device, right where this lead protector is. So we'll take off the connector. And put the device in here. There is a lock that you can hold the device to the ferrule with this locking pin. A little torque wrench. Slip this under the skin. And then typically we'll have two electrodes here, and we'll load them both into the cap. And you want to be careful to mark your electrodes so that you don't confuse left, right. I'll typically tie a silk suture around the electrode to mark it. And there's a line on the electrode that will tell you when it's fully engaged in the housing. Then you screw that down, and then I will tuck extra wire again underneath the scalp to get it out of the way. And then, as you can see, when we close up, we'll be the leads will be coming off anteriorly, and when we come back for a battery change in the future, which again is typically about 6 or 7 years right now, we'll be able to open up just this part of the incision and then take out this locking screw again, take this cap off, and then change the battery and put the new one in with the leads. So that basically concludes placement of a bihippocampal RNS placement with a right parietal IPG. All right. Any questions? Thanks.